I guess we'll start since it's just after 1700. Um, Looks like it's just me and you for the live folks, Logan. But
I can't hear you.
oh man, what the beans?
Okay, now I can hear you.
Were your speakers turned down or was it me? Because I didn't change anything.
I don't know.
Well, what the heck? Can you still hear me now?
Yeah.
All right, well, just say something if you lose your ability to hear me, I guess, because I didn't change anything, so I'm not sure what changed. Yeah. Okay, so exam three review is what we're doing today. It's going to be, I think, shorter than the previous reviews we've done just because it is a lot of little things. I wanted to give you guys a general idea of what is going to be on the exam because it's a lot of chapters. Obviously, it's 10 chapters, I believe, going from 15 to 24. Um, so I put some rough percentages on here. I didn't want it to be too specific. So if you actually add these up, they add to 110%, and you only have a 50 question exam. So obviously, I'm not going to make this one 55 questions. This is just a little bit more of a general overview as opposed to last time we only had 3 chapters. So I gave you a very specific number of questions that were going to be on each one. But main things to focus on are going to be cardiac, respiratory, and neuro. Cardiac, respiratory, and neuro make up 2/3 of the exam. They're definitely the most important ones for us. They tend to be have the most life-threatening illnesses contained within them, which, if we talk about, as I've said in class many times, our most important organs: heart, brain, lungs. Cardiac, respiratory, and neuro are the emergencies that directly affect heart, brain, lungs. So hopefully that makes sense. Um, and then we're around 5 or 10% for pretty much everything else. There's a little bit more on toxicology and on endocrine and hematologic disorders. Even the endocrine and hematologic disorders, within that, it's mostly endocrine because it's mostly diabetic questions, because that's one of our other most common calls that we get as EMTs. And then toxicology is just an important one to know because toxicology as a concept spans a wide breadth of things. Obviously, there's the very common ones that we see, like overdoses on medications. And then there's also the less common disaster response type things when we have like terrorism or large industrial incidents. We need to be aware of those as part of our toxicology as well. Other than that, GUGI is a little bit less just because there's a little bit less content in it, but also our scope of intervention is a lot lower for most of our GUGI problems. Allergies, I could have made bigger, but since we've already covered it on 2 other exams, I just didn't feel like it was warranted to talk about allergies more and more and more. So these questions focus more on the physiology of the allergic response and less on, oh, they're having an allergic reaction, I should give them epinephrine, because we had that on the pharmacology exam. We also had that on the airway exam. So a little bit less on that for that. And then behavioral health and gynecology are just smaller chapters, so there's a little bit less content, so there's a little bit less question asking that I'm going to do on them. But this is the broad scope overview, and then there's about 10% of the questions come from that chapter 15 medical, like initiation, medical overview, and they're mostly about assessment and the process of our assessment for a medical patient. So for those of you last class that got to practice medical assessment with myself or watched RJ and I do it in front of the class, a lot of these questions fall somewhere along the lines of what's part of your primary assessment, what do you do before you get into the secondary assessment, when do you go to the ambulance, do you have a high priority or low priority patient, things to that general nature. So that's our overall breakdown. And I just wanted to put that up there so that I could make sure everyone everyone had a general idea of what was going to be on the exam. On the other side here, I've written ABC, and the whole reason I put this up there is just I want you to keep in mind, very important to keep in mind for this exam in particular, that our ABCs always come first. It's just one of those things where we need to be aware of the fact that when we're given a patient presentation in a question, and you look at the question and you say, I think that this is an endocrine emergency, they are hypoglycemic, et cetera, et cetera, et cetera. But the question says in it that we have something like slow, shallow respirations. We can't get so locked in on how happy we are that we figured out the pathology of the illness, which is that it's an endocrine issue. We need to remember that our airway has to come first and our breathing has to come first. And we need to focus for that patient on managing their airway. And then secondarily, we can maybe take a glucose, try and figure out what's going on. Maybe we can get enough of a response to give oral glucose. But our A, B, and C have to come first. And that comes up in a lot of questions on this exam, and I want you guys to remember that. Because there's just a lot of times where you're going to read the question, and taking that same diabetic question, for example, give oral glucose might be an answer option, and you can't let that distract you from the fact that A, B, and C have to come first before we can move on to giving oral glucose, because that might be the eventual treatment for the issue that we're having, but these are more critical in making sure that our patient stays alive long term. So I want you to really keep those in mind for this exam. Okie dokie. First thing I want to say is just a quick note. It's something I've said before in class, but when we get test questions or when we're at our PSE, we obviously in our PSE we might have a mannequin or a real person in front of us that's an actor. When we arrive on scene, it's usually easy to tell by looking at a person if they have like rapid and shallow respirations, if they are adequate or not. A lot of times visually we can figure that out, whereas on a test question we can't see that necessarily. So I wanted to just to preempt you for this exam and your trauma exam and for your state exam. Usually when we give you a patient presentation and it includes shallow in the text, we're telling you that it is so shallow that it is inadequate. Sometimes we'll just straight up say they have inadequate breathing, and then you remember ABC, I need to focus on my breathing before I can focus on my treating whatever illness I might think they have directly. But because we can't put a real person in front of you, usually rapid and shallow or slow and shallow are the way that we try and tell you this person's breathing is inadequate. Because I understand the complaint, and I had the same complaint when I was in EMT class, that, well, sometimes I have a patient with shallow breathing, but the shallow breathing is like, I'm using a lot less volume there than I normally would. And sometimes the shallow breathing is so shallow that we're only ventilating dead space, and obviously that person needs the BVM. You can't see that. We can't show you that really in a test question. So this is the method that we use. Usually when we say shallow, we mean so shallow that it is not effective and it needs to be supplemented by you as a healthcare provider. And I just want to make that as a quick note before I get into the other things. All right. First thing that I want to get into, talking about cardiac issues, is the flow of blood through the body. So, God, I'm just such a terrible artist. we have our heart here. And it has a big vessel that goes to it, the vena cava, and yes, the vena cava comes from the top and the bottom, so there's superior and inferior, but we have a vena cava, superior, inferior, and then we have an aorta coming off of it that goes to a bunch of places, and then we also have our pulmonary arteries that go to the lungs. And our pulmonary veins that come back from the lungs and go back into the heart. So really I just want to quickly review the flow of blood into the heart, into the lungs, back into the heart, and then out to the body. So let's start here in the vena cava. So this is our inferior vena cava, which we often abbreviate as IVC, and then SVC for our superior vena cava. This is deoxygenated blood, which is coming back from the body. So down here, it interacted with some cells, it gave away its oxygen, it picked up some carbon dioxide, and now it's going to come back, and it's going to start here in the the right atrium. So the right atrium is where all of our blood goes to start. When it comes into the heart, it always goes into the right atrium from the vena cava. Then we drop down from the right atrium into the right ventricle. Remember, our atria are a little bit weaker. They only need to be able to squeeze blood from right here to right below it, and gravity assists them a little bit, so they don't need to have a whole lot of strength to them. The right ventricle is then going to pump, and it's going to send blood out the pulmonary arteries to the lungs. So here in the lungs, blood comes in. We'll put a little alveolus right there. So this blood comes into this alveolus where there's a bunch of oxygen. And once it saddles up to this alveolus, the oxygen comes down into the blood, and then it goes back and meets up with the pulmonary vein and flows back towards the heart. And then same thing on this side. And it lands itself in the left atrium. Now the left atrium is on the left side of our heart. It's still a little weaker because it still only needs to push down into the left ventricle. So it's going to push down from there here into our left ventricle. And this is our big muscly part of the heart. Huge portion of all the musculature of the heart is just here in the left ventricle. Now the right ventricle is still stronger than the atria. It only needs to push blood, not even a foot away. Our heart's right here. My lungs are on either side right here. My right ventricle is sitting probably somewhere about right here. And it only needs to push blood to right there. My left ventricle has to be big and strong so it can push blood up and out the aorta. And that blood needs to go up to my head, out to my arms, and down to the rest of my body. Now the biggest fight it's fighting, obviously, is to go up to the head, because it needs to fight gravity to go upwards towards the head. But it also needs to fight gravity a little bit to get out to the arms, because like we talked about in RJ's lecture on aneurysms, there are some little branches, make our aorta arch appropriately. there are some little branches that come off the aorta and send blood out and upward to the arms and to the head. And the reason we talked about in that class, we'll take a quick sidestep here to talk about aneurysms. The reason we get that blood pressure difference is when we have one of these aneurysms in the ascending aorta in this little arch here. If we get an aneurysm right here, so we have our layers of the aortic wall. If we get that little tear and this starts to balloon outward right here, the pressure difference for a branch coming off close to that aneurysm is going to be different than the pressure difference going to an aneurysm or going to a branch that goes farther away in the other direction. So we have the left, we have the right arm, and depending where the aneurysm is, we see the effects differently between the two arms. That's why assessing bilateral blood pressures when we suspect an aneurysm can be such a good indicator. Not having differences in bilateral blood pressures might not rule out an aneurysm, but having different bilateral blood pressures might not only rule in an aneurysm, but rule in that it's severe enough to be causing that difference between the two. And we know that we need to hot-foot it, preferably to a place that has cardiac surgery, but in our case, probably to the airport or to whatever the closest hospital is, so that patient can go emergently down to Syracuse, which is usually where we send our people that need emergent cardiac surgery. I told you guys about the patient that I transported. She had a big aneurysm right here at the base of the aorta. And we sometimes call this an aortic root aneurysm because this is the root of the aorta where it locks down into the heart. And she had ballooned up that huge portion right there. She had to be transported to Syracuse because Syracuse can do surgery on these. And remember that inside, this is what we're looking at. If you can see those few different lines that I made, inside there's a tear and blood that should just be going up and out like that is also going and filling in this space between the layers of the blood vessel and causing this to balloon out more and more over time. And that's our aneurysm. That's why we have aneurysms. I don't have a whole lot left to say about blood flow. This is just mainly that I wanted to put this picture back in your head. There are some other, honestly, better pictures on the internet. I can pull one of them up quick. Blood flow through the body. Where's the one that I'm looking for? There it is. I'll share my screen here in a second. Oh, this is a little blurrier than I wanted it to be. But this is our blood flow image that I really like to see. Sometimes you see a little bit of lungs up here, but down here we have the capillaries of the body, and they come, up through the vena cava into the right atrium, down into the right ventricle, and then up and out to the capillaries of the lungs where they get oxygenated, and then back down into the left atrium, down into the left ventricle, and out once again to the systemic capillaries of the body. All right. One last quick note I'll make here, and I think that I talked about this a little bit in a previous review video, but I'm not 100% sure, so I want to point it out again. We know that our heart also needs its own blood supply. And for that, we have our coronary arteries. So we have an artery that comes down the front here. We have an artery that goes around the back. We have another one that comes down over here. We have one in the back that is, you can't quite see it in this image where we're looking at it from the front. But we have what we usually, the one we're most concerned about, this big one that I've drawn here, our left anterior descending. And then we have our other coronary arteries that go around as well. The way we feed those arteries is up here where the aorta comes off the heart. We have 2 or 3, I can't remember exactly, little holes that go to the arteries that feed the heart, and over top of them we have a little flap. Now it's very notable for us because the way that our heart gets its oxygen is different from how all the rest of the body gets its oxygen. So normally, for everything but the heart, when the ventricles squeeze during systole, or systolic motion of the heart, the ventricles squeeze, this flap gets pushed up to cover these holes, and blood flows to all the rest of the parts of the body. This is going to be a comically oversized heart for this imaginary person that I'm drawing, but our heart squeezes and it pushes blood out to all of these other places. Our heart itself gets its oxygen supply because when the heart relaxes during diastole, this flap opens again and blood can flow into the coronary arteries and fill all of these places with blood, allowing the heart itself to get oxygen. What that means is that if we're not having a long enough period where our heart isn't beating, we can start to get chest pain and all these normal symptoms of a heart attack because our heart isn't spending long enough unsqueezed for this flap to open up and allow blood to flow to the coronary arteries. So I was just talking about this with the paramedic students the other day, and I'll draw a quick picture. I know we don't interpret EKGs as EMTs. But we know that, or I can tell you that this period right here is where the heart is actively contracting, and then this time in between, so this right here is our systole, and then this time in between contractions is our diastole. That's the time when our heart's relaxed. And we know that we need to spend long enough in diastole for blood to flow down into the coronary arteries because this flap needs to stay open, and the motion of the heart squeezing closes that little flap against those, and the coronary arteries can't fill. So when we have patients, something that we can assess as EMTs, whose heart rate is really, really fast, they might start to have that severe chest pain and maybe some of the hypoxia and the difficulty breathing that we see with our heart attack patients because they're having the same end result happen. If the heart is beating super fast together like this, well, we have a period of systole, and then we have another period of systole, and another period of systole, and another period of systole, and that just keeps going. We don't have this little pause for diastole in between to allow our coronary arteries to fill with blood. Usually what we call this, because it's not it's not a heart attack like we would normally see it, is we would call it a demand ischemia. And it's not something we see super often because when we talk about these fast heart rates, we're talking about really, really fast heart rates usually, like up in the 160 to 200 range, much, much faster than we normally see our patients in. Not just the, oh, their heart rate's 140 because they just came off the rugby field. That isn't this kind of fast. This kind of fast is like, oh, they massively overdosed on cocaine and now their heart rate is going through the roof because there's no time for the cardiac, or their heart rate is going through the roof and therefore there's no time for the coronary arteries to fill in between beats. And we start to get chest pain and a lot of our normal symptoms of myocardial ischemia like we would see with angina or a heart attack. But we call it a demand ischemia because the heart is beating so fast, there's so much demand for oxygen for the rest of the body that the coronary arteries aren't able to fill. I want to stick that as a quick note in there because it's important to remember when we're considering the possibility of demand ischemia, but also when we're thinking about our blood pressures. So I have pushed the term MAP on you guys a lot, mean arterial pressure, but if MAP was the end-all be-all of everything, then we would only ever talk about MAP and we wouldn't talk about our normal blood pressure, which is our systolic over our diastolic. The reason both of these numbers matter is because our systolic needs to be high enough to push blood out to everywhere else in the body, but particularly the brain and the lungs. And our diastolic needs to be high enough that when this flap opens, blood still has a little bit of pressure behind it to push it out to the coronary arteries and keep the heart oxygenated. I know it seems like it would be weird that we would keep both of these numbers just so we could worry about, this number attributing to one organ. To be fair, the diastolic does matter in more context than just the heart, but it's a little bit outside this scope. And keep in mind that the perfusion status and the activity of the heart is what we use to define aliveness. We say that someone is dead not when the lungs stop working or not when the brain stops working, but when the heart stops working. Cardiac arrest is our definition of death, basically. So our heart is really our number one most central organ that we think about because it's required to keep all these other things alive. All right. I have one more thing for cardiology before we move on to some other topics. And it starts with the discussion of ACS. Now, at least when I was in my EMT class, we didn't hit the term ACS very hard. But if you continue in your career, or maybe just my EMT class didn't think about this, or I missed it because I maybe wasn't a very attentive student, but this is acute coronary syndrome. And the question sort of arises when we talk about ACS, well, why don't we just say heart attack? Isn't heart attack the most, deadly thing that happens to our heart? Isn't that the thing we're most worried about? Why would we have this extra term ACS? And it's because we have two different issues that fall into the category of acute coronary system. And that is myocardial infarction, which we know is our fancy science word for a heart attack when there's death of that cardiac tissue in the myocardium. But we also have unstable angina. Now, we've talked about angina a bunch of times before, but angina is basically some amount of myocardial ischemia, a lack of oxygen going to the tissues of the heart, but we split it into these two different categories, stable and unstable. You recall that there's one main thing that differentiates our stable angina patients from our unstable angina patients, and it's that our stable angina patients, the pain resolves with rest. So when we're having myocardial ischemia, unstable angina might start because we go out and we're stacking wood, something that I had to do all the time when I was a kid. You're out there and you're stacking wood, you're working your body, and your coronary arteries are vasoconstricting a little bit because all the arteries of your blood or of your body are vasoconstricting a little bit to keep your blood pressure up because you're working hard and you need the extra oxygen delivery to your heart and the rest of your body. So we get a little bit of vasoconstriction. In our stable angina patients, their coronary arteries might look like this, or flip these colors around. Their coronary artery, this is, through the tube view of the coronary artery. Their coronary arteries might have some plaque buildup in them. And then when they vasoconstrict, that plaque starts to take up more of the space. So now our coronary artery is only this big, but the volume of plaque doesn't get smaller, just the lumen itself, which is what we use to mean the hole in a tube when we're talking about tubes of the body. We call that the lumen. So now a huge amount of this coronary artery is filled up with this plaque, and less oxygen is getting delivered out to the tissues of the heart, and we start to get chest pain because we have myocardial ischemia, a lack of oxygen without tissue death. Now, in our stable angina patients, when they stop working out, I'm out there stacking wood and I say, oh, my chest is really starting to hurt. I'm going to go sit down in the garage. I go sit down in the garage, I relax for a few minutes, my coronary artery opens back up again, my plaque is only taking up this much of it, and more blood flow is now flowing again. And my chest pain relieves because that myocardial ischemia, goes away, and I'm getting full oxygenation to my heart again now. Those are our stable angina patients, and their pain resolves with rest. Our unstable angina patients, their pain might still come on with exertion, or it might come out of nowhere, but the thing that really differentiates them is that it does not resolve with rest. So the question comes up once again, okay, so back to the beginning, well, why do we care about this whole acute coronary syndrome thing? Well, as BLS providers, if we respond to a call and it's, 65-year-old male, he was outside stacking wood and his chest started to hurt really bad, it was a real tightness or a pressure in his chest, went inside, sat down in a chair for a little bit, took a few deep breaths, and now he feels better. We can make sort of put high on our differential list, our field impression might be that he has stable angina. But if his pain doesn't resolve with rest, we can't say, is he an unstable angina or is he currently having a heart attack? We don't have a way that we can tell the difference between the two. Even as ALS providers, there's one kind of heart attack that we can identify and we can relatively definitively say, okay, that person is having a heart attack. But what we can't do is for those patients that aren't having that one specific kind, just like BLS providers, we can't definitively say if it's unstable angina or an infarction because not every heart attack is going to have changes on an EKG that's what we're going to use as a diagnostic tool. So the American Heart Association in particular takes these two things, myocardial infarction, a heart attack, and unstable angina, which is chest pain that doesn't get better with rest, and we call them acute coronary syndrome because in either case, less oxygen than is necessary is getting to the heart because the coronary arteries are not flowing enough blood to the heart. We can't definitively differentiate between these two, so we lump them together in one category that we call acute coronary syndrome. This term is something that we, can use in the field a lot more because we can't know for sure if it's a heart attack or unstable angina. But if they're having, high pain rated crushing or tightened chest pain radiating down the left arm, all these tools that we use to identify something that refers to a lack of oxygen to the heart, then we can make a field impression that they could be having acute coronary syndrome, or we can at least have it as a high index of suspicion, even though we can't definitively say one or the other. So this is just a term that I want you guys to keep in mind, acute coronary syndrome, in addition to these terms that I think you already know, stable and unstable angina, and then myocardial infarction. Honestly, even just as an aside, in the hospital, we can't always definitively tell the difference between these two things because the standard that we usually use to say we think this person might be having a heart attack is that we look at that that lab value called troponin that RJ's talked about in class before, but both of these can present with higher troponin levels. Just usually unstable angina might present with consistent or dropping, or let me get in the place where this is more visible, consistent troponin levels or dropping troponin levels, whereas an infarction is more of a upward moving of troponin levels because we expect the heart to continue to get more and more damaged over time. But both of these are bad, and we don't have a field impression way to tell the difference between the two of them, so we lump them together into this one category that we call acute coronary syndrome. Coronary here referring to the coronary arteries of the heart. All right, moving a little bit more into neuro. We're going to start with seizures, and then we'll talk about strokes a little bit. So our seizure patients, the main things that we need to be aware of as EMTs when we treat seizure patients is just what we have available to us as treatments and the process that we expect people to go through when they're having a seizure. So before someone has a seizure, we'll break this up into sort of three separate categories. So before someone has a seizure, we have a few possibilities of what that person could feel. Some of them will feel nothing. Some people that might have epilepsy or other chronic seizure disorders might not act differently at all, and then there's an outside stimulus or just something else and they start having a seizure. Other people, especially those that have had seizures for a long time, might have what we call auras, where there are visual changes that happen, and that person knows that those visual changes are indicative that they might be about to have a seizure. And we call those visual disturbances that happen auras. And then the last thing I'll throw in here is trauma. For those patients that don't have a history of seizures, trauma can be something that can cause them to have a seizure, especially head trauma, trauma that affects the neurologic system, that can preempt them to having a seizure. And then because we'll talk about it here in a moment, I'll put illness. Our septic patients can have seizures sometimes. Our diabetic patients can have seizures sometimes. But at least in my own personal experience out there in the field, the majority of seizure patients that I've had have had a history of seizures. All right. During the seizure. So during the seizure, as EMTs, we have really two main goals: airway management going back to our ABCs. We're going to manage the airway however that's appropriate for that patient. It might be a non-rebreather. It's possible that we'll need to perform some kind of airway maneuver like a jaw thrust or putting in an NPA. But more on the general whole, airway management is our number one priority for an actively seizing patient. And then our other one that we're going to focus on is protection. I'll just put it up there very generically like that. Now, we don't want to necessarily restrain someone that's having a seizure, but we do want to generally protect them from harming themselves. So if someone is lying supine having a seizure on a concrete sidewalk, which is a drill I used to often put my lifeguards through, we might put a folded up t-shirt behind their head to stop them from smacking it back and forth and hurting the back of their head by banging it into the sidewalk. If they're persistently, smacking themselves in a way that you think might be harmful because of the clonic movements of their arms, then maybe we'll in some way very gently restrain or redirect the seizing patient. But we aren't going to put seizing patients on our stretcher and, really strap them down in restraints to prevent their body from moving around. It's just usually not safe for them, and it puts them at risk for positional asphyxia, where they can't breathe appropriately because we've secured them so strictly, and that starts to harm our airway management, which always needs to be our number one priority, is airway management.
Before we get away from seizures, what has to be done with
someone having a seizure and then getting the head trauma from it?
What do you mean by what has to be done, Logan? I'm a little confused by your phrasing.
Is there do you treat the seizure first and then the head trauma, or the head trauma and then go back to the seizure, or?
So as EMTs, we don't have really good direct interventions for seizures. If you had an ALS provider there and they could treat the seizure directly with a sedative, then we would probably sedate the patient and then move on to whatever soft tissue injuries we can control on the head. As an EMT, I would probably walk the line of whether or not it's an ABC issue. So if they're having an exsanguinating hemorrhage from their head somewhere, then we might try and at least put pressure on it while they're having a seizure. If they're bleeding or they have some other soft tissue injury to the head and it's not an immediate life threat, then I would manage the airway, let the seizure end, and then go on to bandaging. Because in terms of head trauma, that's really the end of most of our direct treatments is soft tissue injuries to the head, bandaging scalp lacerations or something like that. Even when it comes to more severe head trauma, like a depressed skull fracture, we're just going to be bandaging that the similar ways that we would bandage any other soft tissue injury. And we'll talk about that a little bit more when we get to trauma. But unless they're having an issue that is directly affecting their ABCs, I would hold off on treating the whatever head trauma things you're going to treat until after the seizure ends.
Okay. I just was curious because I've already had a patient who went through a seizure and he had a small laceration on the back of his head. So I just was curious.
Yeah, something like that. Like our head, bleeds a lot. Our scalp is very vascular, and our face especially is very vascular. But none of them are exsanguinatingly vascular. Even if there's large amounts of, there appears to be large amounts of blood, they usually aren't at risk of dying from it. So not something we have to worry about too much. But if we had something like, trauma to the head and it also lacerated the neck and you think that their carotid artery or their jugular vein might be bleeding, then yes, I would probably like hold direct pressure on that while they were still seizing, because that is going to be an immediate life threat. And we'll manage that and airway management during the seizure. And then we might, dress this up a little bit more pretty after the seizure has ended.
Okay.
And in that context, I keep saying after the seizure has ended. Most often, seizures are something that start, they happen, and then within some amount of time afterward, they end on their own. However, that is not always the case. Some patients might just seize continuously until they end up coding, and then we have to go into our CPR algorithms. If we've been sitting on scene waiting for a seizure to end for a long time, then we need to figure out how to most effectively get that person to a place where they can directly treat the seizure to try and get it to end. And whether that's intercepting with ALS or just transporting to the closest hospital, we need to figure that out after that 5-8 minute mark of continuous seizure has happened. That seizure may not break on its own. It may only break with pharmacologic intervention, and we don't want to wait until that person goes into cardiac arrest before we just realize, oh, I guess that seizure's been going on too long. So keep that in mind. I keep referring to seizures as if they're something that just starts, happens, and then ends. But seizures can be something that start and they just go and go and go until either the patient dies or we intervene in a pharmacologic method, like an ALS provider or a physician might do in the hospital. So, all right. So those are before stages. It could be nothing that's happening. The patient might be aware that they're about to have a seizure, or we could have one of these other things that is prompting the patient to have a seizure. During the seizure, number one priority is airway management, and then number two priority is keeping the patient safe from themselves and from the activity of the seizure. And then after the seizure, we have a few things. Obviously, number one still stays our ABCs. We want to make sure that those are intact. Our patients could come out of seizures still with respiratory depression or something like that, where we need to intervene on the ABCs. And then we have observation and vitals to check those things after the seizure, and supportive care for our postictal patients. Now remember that this after phase, I just said it, we call post-ictal. Our post-ictal patients. Our post-ictal patients might take a few minutes to wake up. They might take barely any time to wake up at all. But usually, at least when they're first waking up, they're going to be confused and they're going to be fatigued. And we expect after a seizure for people to have gradual improvement. That gradual improvement might be over 5 minutes, it might be over 10 minutes, it might be over 15 minutes. But we expect them to be persistently getting better. If we have a patient that has a seizure, comes out of the seizure, wakes up, is confused, and then starts to get more and more confused, and it looks like they're trending downward, that might be a sign that we're about to go into another seizure. We expect our postictal patients, even if it takes a few minutes, to progressively improve until they get back either to their baseline or something very close to their baseline. Either way, these patients are probably going to feel exhausted and a little foggy, but we should be getting back close to our baseline after 5 or 10 minutes. So that's our normal flow. I wanted to cover that flow a little bit. Usually we're not going to be there for this before stage unless it's in the context of trauma or illness. And then maybe we'll arrive to a trauma patient, get them on the stretcher, and then have them start seizing. Usually we're going to be arriving during or after phase of our seizure patients, because they called 911 because the person was having a seizure, which means we weren't there before it started. A couple more ways that we break up seizures. They can be generalized or they can be focal. And when we say generalized here, we mean general the way we mean general in general anesthesia, meaning that they affect the entire body. And when we say focal, we mean one point or one side, but either way, they affect less than the entire body. They're not affecting everything. We could see, just neurologic changes on one side or in one limb or just in the head. But in some way, they're not affecting everywhere in the body. Our patients may remain semi-aware during these, whereas during a generalized seizure, our patients are not conscious and interacting with us. Their entire body is involved in the seizure activity. I'm not going to talk about every kind of seizure. We do have a whole lot of them now. What was I just thinking of? Focal absence seizures, where in our absence seizures, the problem is that there is a lack of neurologic activity, or there's so much neurologic activity that there appears to us as the outside provider that there's a lack of any activity at all. A lot of times, those are the ones that we might see in kids where they're just sort of stiffened up and they have maybe some eye movement, but not the big body shakes. We have psychogenic non-epileptic seizures, the ones that we used to call pseudo seizures that we know now aren't really, they're not something that the patient is faking. It's not something they have control over, but it's also not the same mechanism as our other types of seizures. That's why we call those psychogenic non-epileptic and not pseudo seizures. But I will take a moment to talk about our most common kind of seizures, which are tonic-clonic seizures. So we used to call these grand mal, which is funny for those of you that took French in high school might remember that grand mal means big bad. So these are our big bad seizures. Our tonic-clonic seizures are relatively identifiable because they have that very classic seizure presentation that we're looking for. So a generalized tonic-clonic seizure is going to have two phases of the seizure itself, not the before, during, after we were talking about, but two phases of just that during, and those are our tonic and clonic phases. Our tonic phase is usually quite brief. Tonic refers here to tone, meaning that we have a sudden body-wide increase in muscle tone. So when we're in our tonic phase, the whole body sort of stiffens up all at once. All of our muscle tone increases at once, and the patient goes very stiff. And then when we enter clonus, that phase is the very classic, wild muscular movement that we attribute to a seizure. So when we arrive on scene and maybe the patient is currently in clonus or they're now postictal, they're not seizing at all anymore, and the family members say to us, yeah, they fell over and then they stiffened up and then they just started, shaking like crazy, that is going to be that generalized tonic-clonic seizure that we usually attribute as like our big main type of seizure that we think of when we think of a seizure patient. This isn't the only kind of seizure that is dangerous. It's certainly not the only kind of seizure that needs intervention. I listened to a great podcast from some pediatric EMS physicians where they had an episode about seizures, and they talked about particularly the importance of directly treating absent seizures in pediatric patients because they can be easy to miss sometimes, and they can be just as damaging to the body as these generalized tonic-clonic seizures are. And to some degree, I want you guys to just be aware of those words because they are, how do I say this? They are good things to use in your charting, like we've talked about many times before, using good, accurate medical terminology in our charting and in our conversations with physicians and nurses and advanced practice providers. Those terms make us appear more professional, and they can convey to the people that we're talking to that we know what we're talking about when we speak to them. So often in my charts when I have seizure patients, I'll refer to arriving on scene to find the patient having clonic activity because I missed the tonic portion earlier before they started having that episode of clonic activity. Or I might say that I was with a patient and I noted a period of tonicity prior to them having clonus. And then, I gave them the sleepy meds and they stopped seizing. Which I've only done a handful of times at this point. But it's interesting how fast it works. The only other thing specifically, I have a couple things. One is about transporting seizures. So there's two sides to this, I would say. There's one question of when do we transport a patient who is actively seizing? And I mentioned that a little bit already. It's somewhere along that, we've been on scene or we know they've been seizing for upwards of 5 to 8 minutes. Because remember that 5 minutes is our bar for status epilepticus. Status epilepticus is an immediately life-threatening condition, and we say a patient's in status epilepticus when they've had 5 minutes of continuous seizure, or they've had 2 seizures back to back without regaining consciousness in between. That is status epilepticus. It's immediately life-threatening, and it needs to be treated either at the hospital or by an ALS provider. So if we know that this situation's been going on for 5 minutes, or we know they've had multiple seizures without regaining consciousness, then I would say, as much as it's going to be a difficult and it's a less safe transport for the patient, we need to get this patient moving either towards ALS or towards the hospital. The other question that comes up here is, can someone that just had a seizure refuse transport? Now remember that in the broad scope, if the patient just had a seizure and they're alert and oriented and competent to refuse care, then yes, they can refuse transport to the hospital. We can't force them to go. But in terms of our thinking as providers and making our recommendations to the patient saying, I think that you should go to the hospital for this, there are a few things that are contributing factors to us making that decision. And they really fall under the lines of if this was their first seizure, if they've never had a seizure before, then, really we should get checked out at the hospital for it. Or if they have a history of seizures, but they're usually well controlled. So if we have a patient that is, 30, 40 something female patient, let's say, and they got diagnosed with epilepsy when they were 11 years old. They've taken Keppra. We'll throw that up there just because it's a good word to know. Keppra or levetiracetam. Levetiracetam? I think I spelled that right. Honestly, if I didn't, I apologize, but it's a long medication name. So Keppra, which is the brand name, or levetiracetam, or levetiracetam, I don't know, is the most common seizure medication that we'll see patients take at home every day to manage their seizures. If you have a 35-year-old female patient, let's say, she got diagnosed with epilepsy when she was 11 years old. She's been taking Keppra every day since then, and she hasn't had a seizure now in 15 years, and then today she had a seizure? That's weird. We need to sort of think about that similarly to the way we think about our patients that just had their first seizure ever. If you don't normally have seizures, and you just had one, even though you've had them in the past, you don't usually have them. There's some kind of process that was going on that triggered you having this seizure. That can be different for a lot of different people. It could be illness, it could be changes in other medications or changes in these medications. It could be that these medications need to be increased and you haven't seen your neurologist in a while, so they haven't been increased. So keeping those things in mind, those patients honestly should probably go get checked out as well, because they might need a bump in their Keppra dosage or something else. They might need a different anti-seizure medication, or they might need a seizure rescue medication, something like that. For our patients that maybe are in flux with their medications, they're trying to figure out whether or not what the appropriate dose is for their medications. We call that the therapeutic window. We could administer from this many milligrams to this many milligrams, but it works, in this range here. That's our therapeutic window. If they're trying to figure those things out right now, and they've been having, one seizure a week for the last month, and the only reason that anyone called 911 is because this time they happen to have their seizure in the car in the Walmart parking lot or something like that, and they're competent and aware and able to refuse care, then those patients, we might be a little bit less concerned with allowing them to refuse care, because this is something that's normal for them. A lot of our seizure patients might fall under this category. They are adults who are competent to refuse care, and having seizures is something that they live with. They're aware of it. They know how to keep themselves safe from it. They might have things like auras that tell them they're about to have a seizure, and then they can put themselves in a place where it's safe for them to have a seizure. Just lay down on a nice carpeted floor, allow it to happen, and then they regain consciousness afterward. But when we're having these kinds of things, they've never had a seizure before, or it's just not normal for them to have seizures, they're usually well controlled, then we want to push a little bit harder and say, hey, I think we should go get checked out at the hospital. Same thing with other factors, if they have a history of seizures and they're normally well controlled, and this seizure happened right after they fell and hit their head, we should go get checked out at the hospital. If they had a seizure in a pool, that was a big one. When I was a lifeguard, we had 5 reasons that we had to call 911 if someone had a seizure. Now that person could still refuse transport if they want to, but when I was a lifeguard, we had 5 criteria that if they met any one of those criteria, we had to call 911 and at least offer EMS transport. If I remember off the top of my head, I think it's if the seizure happens in the water, if it's their first seizure ever, if the seizure lasts more than 5 minutes, if they are a child, and I can't remember what that last one was. But either way, we're not lifeguards, we're EMTs. We have a higher, scope of responsibility than I did when I was a lifeguard. So these are things that I just want you to keep in mind when it comes to transporting patients that have had a seizure, sometimes it is appropriate to allow a refusal of care and that patient might be fine. But sometimes we need to have that more frank and honest conversation where we say, I really think that you need to go to the hospital. And if they still want to refuse care and they're competent and able to, we can contact med control and see what they think. But obviously we can't really force things on competent adults. These are just points to keep in mind when we're telling our patients, I really think you should go to the hospital. Here's the reason why. This is the first seizure you've ever had. We don't know why you had the seizure, or you haven't had a seizure in 15 years. Obviously something changed today that you did have a seizure. Let's go get checked out. Keep you under observation for at least a couple hours, see if you have another seizure, and then we can call your neurologist and see if, an increase in your Keppra dosage or a different medication is warranted. All right, last thing on seizures, I want to talk about febrile seizures. So, febrile seizures, the first thing our mind normally goes to is kiddos. Febrile seizures are certainly our most common kind of seizure that we see in children, and they're usually relatively easy to identify because febrile is our $5 science word for fever. So if we arrive on scene for a 5-year-old, 6-year-old, 2-year-old child, and mom says that they were shaking and wiggling all over the place, and then mom also says that they've had the sniffles recently, and we read their temperature and it comes back as 103, well, that kid might have had a febrile seizure. Something to certainly keep in mind when we have children who are our patients. And I'll throw in here as a quick learning point that when we are looking at our patients that we are considering for a febrile seizure, one of the things we've learned in research over the last little while is that the fever itself might not be what really causes the seizure. It's the sudden spike in temperature that causes the seizure. So if we have our little graph here of time and temperature, our kids that are sick and they might have a fever and their fever, is increasing something like this. This is their temperature going up over time. Those kids might be less likely to have a febrile seizure compared to a kid whose temperature isn't as high, but spikes really quickly, and this is where we see that seizure onset. And it's not a definitive measure. The kid could have had a fever for days and now they have a seizure and it might still end up being a febrile seizure. But what we've seen is that a rapid change in temperature more predisposes kids to have febrile seizures than just a high temperature on its own. You warm the brain up too quickly and it just freaks out. Okie dokie. I'll also say that our febrile seizure patients should pretty much always get transported. Once again, within the scope of what we're legally able to do as EMTs, we can't force transport on that person. But febrile seizures can be immediately life-threatening, and that child may need some kind of pharmacologic intervention to bring the fever down, like IV Tylenol or something like that. Okay, moving on from seizures to strokes. Our other main kind of neurologic emergency. Strokes are very life-threatening. Lots of people die from strokes, unfortunately. And they're part of, or some strokes are part of what I have been calling recently, because I'm putting a CME together on this, are big three ischemic diseases, which are pulmonary embolism, stroke, and heart attack, because those are main three organs, and those three disease pathologies stop oxygen from going to those organs. So we have completely different presentations a lot of the time, but similar background as to what's happening. For some reason, a clot or atherosclerosis is blocking oxygen from getting to that organ. And if that organ is the heart, the brain, or the lungs, we need to be very acutely careful of it because those are our most important organs. All right, so let's start with evaluating our stroke patients. Now, any patient we have that has altered mental status or like neurologic changes of any kind, changes in sensation or changes in motor function, we should at least do a stroke assessment on, because honestly, for one thing to keep in mind, a stroke assessment takes 30 seconds, and it could help you find something that you would have missed otherwise. And I'll put up here the stroke assessment that I use, which is the FAST-ED. Now, part of the reason I use this is it's because it's what my medical director wants me to use. So FAST-ED stands for facial palsy, arm drift or weakness, slurred speech, or sometimes people will put speech changes. Some of our patients might not have slurred speech, but they have difficulty forming words and sentences, even though they come out clearly, and those would still be speech changes. Time since the onset of symptoms, or as we usually say in EMS, time last known well, or this is the number we usually focus on in EMS, is time last known well. Down here at the bottom, eye deviation and denial/neglect. And we'll run through each of these quickly, just how we assess them. So facial palsy, usually we'll ask our patients to smile. I usually say, can you give me a big smile with your teeth? To which the fine folks of the areas that we live in say, I ain't got no teeth. In which case I say, smile with your gums. And that can give us a good indicator as to whether or not there's a little bit of droop on one side. Arm drift or weakness, we usually say, hold your hands up in the air like you're holding 2 glasses of water, shut your eyes, and then keep them there. And we watch as EMTs. If they hold them both up like that, then there's no drift. And if they have a little bit of, loss of motor in one of the arms, then we do have drift. Slurred speech or speech changes. Slurred speech itself is relatively easy to identify. I usually will ask my patients to say it's a sunny day in whatever place I am. So I'll say, can you say to me it's a sunny day in Messina, or it's a sunny day in Potsdam, or something to that effect. In terms of speech changes that aren't slurred speech directly, having some kind of aphasia where they can't get words out appropriately or something like that, that can be harder to identify. If they're completely unable to speak, then obviously that's a speech change. If they can't form any words and they can only make noises, that's an obvious speech change. But it can be hard sometimes to tell the difference between a moderately confused patient and a patient that's having just an aphasia where they can't find the words they're trying to say because of a cerebral problem and not because they're, a dementia patient or they're just confused or something like that. Time last known well. I slipped up here before, so I'll make a distinction. Time last known well is the last time that someone saw this person and they were acting at their baseline. So if they wake up at 7 a.m. and they're not acting at their baseline and they went to bed at 8 o'clock last night and their husband, wife, whomever saw them at 8 o'clock last night and they were normal, their time last known well is 8 o'clock last night. It could be that their symptoms onset at 5:30 a.m. and now it's 7 a.m. and they're waking up and they've only had it for an hour and a half,
but we don't know when that happened throughout the night. So our time last known well would be the previous day when they were seen well. Our time since the onset of symptoms is a little bit different. That's our time since we identified the onset of this issue. It can be a little bit harder to know for someone that lives alone and then just eventually, like, maybe noticed on their own that their speech was slurred somehow or something to that effect. They might not know when their onset of symptoms was. And they might also not know a really accurate time last known well. Even sometimes we go to nursing homes or something like that. I've had nursing home calls where they call at 7:30 p.m., shift change was 7 o'clock, and now they say, I don't know, this is the first time I've seen him this shift, and everybody from day shift is gone. Well, that's going to make it very difficult for us to put together a time last known well, because maybe this staff member saw them 13 hours ago, but maybe one of the day staff members saw them 2 hours ago and they were normal, but I don't have a way to contact that day staff member. I need to either work with the employees that are currently there, or just run off that 13-hour ago time last known well. This is one of our most difficult things with stroke patients, is trying to get this time as accurate as possible, because what their time last known well is can dictate the treatment that they get later down the line in the hospital. Eye deviation is pretty simple. They'll have one or both eyes that are forced into a certain direction and they're unable to move them. So you say something like, follow my finger with your eyes, and they're not able to move past a certain point, or they're stuck just in one point, looking to one side often. And then denial or neglect is a pretty ominous sign where they don't recognize parts of their own body. So we can have patients who have strokes where you tap their arm and say, whose arm is this? And they say, I don't know. And they don't know. It's a failure of what we call their proprioception, which is a $12 science word. Proprioception, which is our body's innate ability to tell where our limbs are in space without needing to look at our own limbs. Like, I know that my legs are crossed right now, and then I know that my legs are now uncrossed, but I can't see my legs. My body is aware of where my limbs are in space without me needing to look at them and see that they're there. If I tap someone on the arm and say, whose arm is this? And they don't know who it is, then they're having a failure of their proprioception. All right, that's our assessment tool for strokes. There are many assessment tools for strokes. There is the Cincinnati Pre-Hospital Stroke Scale. There is BFAST as opposed to FAST-ED, which is a similar scale, but it's slightly different. There is a new one that might be coming out soon that is called the VAN scale. But that hasn't really been implemented anywhere yet. I believe there's still studies going on testing the effectiveness of the VAN scale. So this is the one that we're most commonly seeing in EMS these days. Okay, how do we treat strokes? Really, unfortunately, it's ABCs. There is not anything that we can do as BLS providers to directly treat a stroke. There's not anything as ALS providers that we can do to directly treat a stroke. It's about supportive care and maintaining our ABCs, and preferably transporting them to what we call a comprehensive stroke center, which is a place that has not only thrombolytics, clot-busting medications, but also has endovascular surgery to go into the brain and correct either the bleed or the blockage that they have. We don't have any comprehensive stroke centers up in this area, so occasionally we will send our strokes with the Sky people through LifeNet or Mercy Flight, and if that's not an option, or if you have a moderate concern for a stroke and you can't get a flight crew, we'll go to one of our primary care stroke centers or our stroke ready hospitals. And that is a slight distinction between those two things, but most of the hospitals in the area are at the very least stroke ready, even if they're not what's considered a primary care stroke center. Maintaining ABCs. The other important thing for stroke treatment is ruling out other illness. We're going to jump right into endocrine disorders here in a second. And one of the main things you want to do with our stroke patients is obtain a blood glucose. We want to, figure out, can we rule out that this is a stroke by obtaining a blood glucose? Maybe we see that it's 40, we give them a little bit of sugar and they come back to their baseline. Well, that's a good, a good likelihood that we can rule out that a stroke was happening here. We can, follow up with our other things as well. We just talked about absence seizures. Absence seizures can present with one-sided paralysis or at least one-sided lack of motor, even if they still have sensory, and that might look like a stroke. That's something that's harder for us to rule out in the field, but keeping in mind these other possible things on our differential diagnosis is our other important piece of treating our stroke patients, ruling out the other things that could be going on here. So asking, do you have a history of seizures, obtaining a blood glucose, finding out, does this patient have dementia or something like that could be causing this confusion. Things like that help rule out stroke as a possibility if they're positive, or rule in stroke if they're also negative. I won't get into it here, but I'll encourage you to look into it on your own time, just because it's not something that's asked about on the exam. But FAST-ED is not only a stroke assessment tool where we go through and say, okay, yes, yes, no, yes, yes. I say it's a yes. There's also a FAST-ED scoring tool where each one of those components of FAST-ED are assigned a point value, and the increasing, however high their score is, increases the percentage chance that they are having a stroke. I didn't put any questions relative to that as a scoring tool on the exam, but I think that it is good to keep in mind. And if you can learn that scoring tool by heart, it's great. If not, there are resources that allow you to score your stroke patients mobily. One of the big ones that most of us are going to have access to as EMTs is when we put a patient in on Pulsera to send our report to the hospital. We can fill out those checkboxes and it will calculate the stroke score for us. And that can tell us, okay, is it a less than 10% chance? Is it at least a 30% chance? Is it a 60% chance? Is it a 90% chance that this patient is currently having a stroke? This was the day that I was absent from class, so I apologize if RJ has already covered the GCS score in depth, but I will cover it again here briefly, just to keep a reminder of it. Remember that our GCS score comes in 3 different categories, and we assign a point value for each. We add those up, and that's our GCS. So for our eye opening, we have 4 different categories of how we score a patient's eye opening. It's either spontaneous, they just open and close their eyes on their own, we don't need to prompt them. It's to sound, it's to pain, or it's none. So hopefully this looks pretty similar to our AVPU scale: alert, responsive to verbal, responsive to pain, and unresponsive. These are, the same kind of categories, but they're just one component of our overall Glasgow Coma Scale. Our verbal scale comes in 5. Best case, they are oriented. If they're not oriented, but they're still, talking and making some amount of sense, but they're just, not fully with it, then we'd say they're confused. If they're able to say words, but they're not able to form sentences, that's a 3. If they're only able to make unintelligible sounds, that's a 2. And then once again, if they're not making any sound, word, sentences at all, that's a 1, that's none. And then motor is our most complicated one. Best case for motor is that they obey commands. I say put your right arm up and you put your right arm up. They're obeying commands. Next best, they score a 5 if they can localize. So if I, like on our trauma assessment, we take the person's foot, we run a pen up their foot and their toes curl or something like that. Or you do a sternal rub and their body goes like that and then goes back into place. Their nervous system is localizing the pain, but they're not necessarily doing it on their own. It's more of an innate response. Obeys commands, localizes. Shoot, I'm missing one in my head. I know the order they go in, but now I'm missing one in my head. I can't remember what point number 4 is. Withdraws from pain. So they obey commands, they localize pain, they withdraw from pain, and then these ones down here are our decorticate posturing. And that's when our patients just have an innate nervous response where all of their muscles are sort of tensed inward. They come towards the core. They're decorticately postured. And that is a little bit better than decerebrate posturing, where all of our body's muscle systems are flexed outward and away. So decorticate comes towards the core, and then decerebrate is not that, it's away. We talked about before in class, decorticate posturing we know is a little bit better in terms of one of these being better than the other. Decorticate posturing is better because it's a natural response for when all else fails, our body protects itself by bringing things to protect the core. And then decerebrate posturing is a complete failure of our body to protect itself even in the most innate way. And then if they have no motor at all, they still get a none. So our best patients are going to score a 15. That's a 4, 5, 6. Those are our patients that are alert and oriented and talking to us and getting up and moving around, totally fine. And then our worst scoring patients are going to score a 3. Remember, we can't score a 0 on the GCS. If we have none, 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 we still score a 3. So best case is 15, worst case is 3, and then everything in between there is some combination of problems with these different assessment tools for our nervous system. Alrighty. Next one I just have is a quick note related to assessing our neuro / even toxicology, all these different pathologies that present with altered mental status, is that one of the main things we need to consider when we're assessing someone for altered mental status is altered from what? What is this patient's baseline before we start saying, are they altered or not? Because once we know that they're altered, we want to consider stroke, we want to consider endocrine disorders, we want to consider, toxicological issues. So obtaining an appropriate baseline is one of our first steps in assessing someone for whether or not they have altered mental status. If we can't, if there's not a family member or someone like that around to tell us that this person is not at their baseline, then we assume if they're not alert and oriented, that at their baseline they are alert and oriented, and this is a deviation from normal. Okay. I'm not going to harp on toxicology too much. Use your textbook, review your toxidromes. Remember, a toxidrome is the collection of symptoms that we use to identify a certain toxin that a patient was released or was exposed to. Some of them we've covered massively in depth, like opioids. We've talked about those lots and lots of times. But review your sympathomimetics like cocaine and epinephrine and MDMA and LSD. Review your cholinergics. Review your anticholinergics. All those different things that, know the identifying markers for each of those different groups of symptoms for each of the toxidromes. Remember your leaky and your not leaky, anticholinergic, cholinergic. I do want to talk briefly about alcoholism and not its short-term effects, but its long-term effects. So obviously, alcohol is a very widely used toxin. We generally use it recreationally for pleasure, but the long-term effects of extreme alcohol use are something that we could run into in EMS in addition to the short-term effects. So we know the short-term effects: altered mental status, vomiting, in worst cases, respiratory depression, violence in some cases. But I want to talk a little bit more about long-term what we can see with alcoholism. And I want to focus on two things. I want to focus on esophageal varices, which are an anatomical consequence of alcoholism. And then I want to talk about delirium tremens, which is a neurologic effect of alcoholism. So esophageal varices, we're going to draw ourselves a little picture here. So this is our esophagus. And then down here is our liver. So why do we get esophageal varices? Where do they come from and what are they? We have this really cool vein that comes out of our liver called the portal vein. Fun name, I know. That vein comes out of our liver and it lines the esophagus as the esophagus goes up. Now there's some bifurcations to it and everything, so it's kind of all over the place. It's not just in one spot, but we'll focus on just this simplified view of it as a learning tool. Now we know that the liver is heavily damaged by chronic alcohol use. That's why our chronic alcoholics end up with things like hepatitis. And when the liver is damaged badly enough, we get a buildup of pressure inside this vein. When the pressure builds up inside that vein, we end up with the exact same sort of situation as jugular vein distension, but inside the esophagus. So remember, when our jugular veins get distended, it's from a buildup of pressure in the heart that's not allowing blood to flow easily. When these become distended, it's from a buildup of pressure because of the liver, because the liver is inflamed from all this chronic alcohol use. And I made the example in class that when we put, a tourniquet on somebody, let me see if I can get these to pop up. We put a tourniquet on and restrict blood flow, our veins that normally might be pretty flat on the surface bulge up really large, and obviously these are now more prone to cutting or ripping and releasing blood. That's why we put one of these tourniquets on before we do an IV, to really plump those veins up and make it easier for us to put a needle into them. When that happens inside our esophagus, we end up at risk for these veins tearing and blood spilling out of them into the esophagus. And then either the blood falls down into the stomach, or it can get vomited upward out through the mouth. Now, really, really severe case, but this was a patient that I had. He was only 35, but he had such severe, he was so intoxicated at this moment when I went to respond to him that he was completely unresponsive, didn't know this was happening, but his esophageal varices were bleeding not only down into his stomach, but it had started to fill his esophagus, where it got to the point where it filled his oro and nasopharynx, and he was basically just pouring blood out of his mouth. And we had to get in there and do a lot of very aggressive suctioning. And at the time, as a BLS provider, aggressive suctioning and an NPA were all I was able to do, because his jaw was clenched tightly shut and I couldn't get an OPA down in there. And even if I had gotten an OPA down in there, I needed to prioritize suctioning, and I might not have been able to get all the secretions out that I needed to with an OPA in place. So this is what's going on with our esophageal varices, is we, have liver damage, which causes these veins to plump up super huge, and then those veins burst, and they start bleeding down into the stomach or out into the airway. Often they bleed down into the stomach. Blood in the stomach is very, very irritating, which causes us to vomit. And now we're vomiting, stomach acid and blood and bile, all these things coming up. And if we're already intoxicated when this is happening, we're not doing a great job of controlling our airway, and we're at huge risk for aspiration and aspiration pneumonia and just general loss of controlling our own airway. Very, very dangerous, something that needs to be treated by the appropriate physician, and there's a lot of different ways we have to treat this depending on the severity of the condition.
So, with the trauma in that, would suctioning make it worse, or is that something we would still have to do?
No, because these tears are down in the esophagus, and we're not putting our suction, the actual varices themselves might be like down in here, talking like vertically. Obviously my esophagus is somewhere here, AP wise, but they're going to be somewhere down here. And our suction catheters go at the most to the back of the oropharynx and the hypopharynx. So we're going to be up here mostly. We're not going to be getting the tip of our suction catheters deep enough to actually really affect whether or not these varices get worse and spit out more blood or anything like that. Aggressive suctioning is really the most critical intervention that we can do for these patients, with the exception of securing an airway with something like an endotracheal tube. But at the BLS level, we're not intubating our patients, so the best thing we can do is probably alternating between BVM ventilation and aggressive suctioning to remove the blood in the airway. And the other stuff in the airway, if there's chunks of stomach content or acid, things like that. Delirium tremens. This is a neuro issue. And basically, delirium tremens is just a response of the body when it doesn't have as much ETOH in its system as it was expecting. When we don't have enough alcohol in our system and we're chronically alcoholic, our neurologic system can start at low levels. We'll have tremors and maybe altered mental status. That's where the name delirium tremens comes from. And in worst cases, our patients can have full tonic-clonic seizure activity from a lack of ETOH in their system. Now, obviously, we don't want to, have these people continue drinking. So sometimes they'll get prescribed benzodiazepines and things like that to help control the actual tremors themselves, rather than saying, drink more and your tremors will go away. Because if they do drink more, they're still going to be killing their liver, all that kind of stuff. So delirium tremens is mostly just a point to be aware of when we're assessing our patients. If they have, bilateral tremors with no history of Parkinson's or anything like that, and they admit to chronic alcohol use, then delirium tremens is something to be aware of. And we also should be aware of the possibility of a seizure happening. If we get called for a patient who's already seizing, maybe doesn't have a history of seizures, and does have a history of chronic alcohol use, then delirium tremens should be something that's high on our differential diagnosis list for what's causing this seizure. But for treating the seizure itself, we're still going to treat it like we would any other seizure. Number 1 priority, airway management. Number 2 priority, patient protection. There is real coffee in here, by the way, if you can't tell from how fast I'm talking at 6:47 p.m. Okie dokie. Okay. I'm going to this is really all I'm going to talk about for GUGI. We're going to draw our little person here. And this is roughly our divider between the abdomen and the thorax. That's our diaphragm right there. So this is our chest, and up in here is where we're going to have our heart and our lungs and the other few things that happen up here. We're going to have our esophagus coming down. Let me move this line up a little bit. Just give myself a little bit more space to work. And then when we get down into the abdomen, the thing that we're worried about for this course, we're going to have our stomach, which is our little pouch here. That's going to go into our small intestine, which is going to be all around and all over the place in here. And eventually our small intestine will go to our colon. Our colon here, which will come around and down to the anus. Also here in the abdomen, we're going to have our liver. Underneath the liver, I'll do this in a different color even though it's famously green. Underneath the liver is our gallbladder. Over here is going to be our pancreas. As well as our spleen. And hopefully we're all starting to get the impression that there's a lot going on in here. There is just a lot to the abdominal organs. Oh, Brian's here. I didn't know Brian was here. Okay, there's a lot to the abdominal organs. Also, back here in the back, we're going to have a couple of kidneys, but those are underneath this jumble of small intestine and colon. And I just want to talk a little bit about assessing patients with suspected abdominal issues and some of the bigger points that we look for in these patients. I guess I'll add one last piece here, which is right in the front. We have our urinary bladder, which is connected to our kidneys by a couple of ureters. So, assessing our abdominal organs. Obviously, the number one tool we have for assessing our abdominal organs is our abdominal exam, during which we palpate the abdomen. And remember, our general process for the abdominal exam as laid out in the text. Yes, Brian, this is being recorded. I'm just not recording it through Zoom, but it is recorded. The general process of our abdominal exam is our patient says, I have pain right here, for example. We're going to move one quadrant away from that and then assess clockwise, with that quadrant being the last one that we push in on. So let's put an appendix right here. That's our little appendix. If our patient says, I have pain right here, that lines up with right there, which means I'm going to go up. I'm going to palpate over the liver and gallbladder and intestine, and I'm going to say, any pain right there? And they might say, yeah, a little bit. I'm going to palpate over here. Any pain there? Not really. Any pain over here? Not really. Any pain right there? Oh my God, that hurts so freaking bad. That's going to be our number one assessment tool, is going to be palpating the abdominal organs. I want to point out a few special assessments we can do that can be very helpful in determining specific spots. Obviously, anytime we do that palpation, if we have pain in a particular area, we want to be aware of what organs are in that area. But there's a couple special assessments we can do to target specific organs that usually cause problems. We'll start with the famous one, the appendix. So the appendix hangs off the large intestine right here. And usually we have very tender area of the abdomen which is reproducible on palpation. One of the other specific tests we can do, though, that's very interesting, is we have the patient lie supine and then we ask them to lift their right leg up in the air. And if they have really, really severe pain in that spot again, that's one of our indicators that it could be an appendicitis. We call that the psoas test. I believe it's spelled like that. There is a muscle down here in your leg which tethers on the appendix. So when you tense that muscle by lifting your leg up when lying supine, it pulls on the appendix, and if the appendix is inflamed, then it causes a lot of pain. So that's one of our very good, very sensitive tests for appendicitis in the context of other right lower quadrant abdominal pain. Other one I want to hit on is the gallbladder. We have two interesting assessment tools for this. Now, obviously, often these patients will report upper right quadrant abdominal pain, but we talked about before in class, there is a nerve that goes from the gallbladder up and joins this plexus of nerves up here in the arm before it goes into the spinal cord and brain. So often our gallbladder patients will have referred pain to their right shoulder. So they might say that their abdomen hurts and they have a sharp pain up in the right shoulder. One of the tests we can use to target the gallbladder directly, I can't remember the eponym for, like the proper name for it. But what we do is normally, so that's the bottom of my rib cage right there. Normally my liver is up here and my gallbladder is kind of tucked up under the rib cage. So what we do is we place our hands here with like a mild to firm palpation, and then we tell the patient to take a deep breath, and we push upward underneath the rib cage, so we're pushing more directly against the gallbladder. And if they report severe pain with that, then we're targeting the gallbladder very specifically, and that can be a high indicator that maybe we have a gallstone or cholecystitis of some kind. Down here for our bladder, obviously our main finding is going to be suprapubic pain on palpation just above the pubic bone. So we palpate right here and they report increased pain. And then we have those other indicators like pain on urination, or particularly burning pain on urination, maybe hematuria, which is blood in our urine. And those can be good indicators that we have a bladder infection or a urinary tract infection. And then last one I'll point out is for our kidneys, particularly for our kidney stones. Remember that when we look at the side view of someone, here are all of our abdominal organs. Up here are our lungs and heart and everything, and there's our diaphragm going across. We have two cavities here. This is the peritoneum, and this is the retroperitoneum. Our kidneys sit back here in the retroperitoneal cavity. So one of the ways that we can distinguish our kidney pain from some kind of pain that we palpate anteriorly on the abdomen is we have our patient sit up or something like that, and we palpate or we percuss, which is this tapping motion, where the kidneys are, and then down where the ureters are, because our ureters come out of the bottom of our kidneys and they go down here to the bladder. And we might be able to jostle that stone a little bit that could be in there, and that causes a really sudden sharp pain, and it can be a very good indicator that we're having a kidney stone or something like that. Other thing that I'll mention in terms of assessing the abdomen is assessing the quality of the abdomen itself. So we want to feel for distension, which is where the abdomen itself is firm and sometimes slightly, usually slightly enlarged. We get more of like a bulbous shape, sort of like what I drew here, a bulbous shape to the abdomen, and it's firm to palpation. And the other thing we might want to look for is abdominal guarding, which is where the abdomen isn't full of something. It's not distended where it has this slightly bulbous shape and it's full, but it feels tense because the muscles of the abdominal wall have become tense. And usually we can feel that difference a little bit, particularly with experience. Our distended abdomens will usually feel sort of like a water balloon, or maybe like a very firm, very overfilled water balloon, where you push on it and it has a little bit of give, but you can tell that it's full of something. Whereas our guarding patients, you can feel that it's very hard, and sometimes you can even feel the muscles themselves. So you can feel the spaces between the groups of abdominal muscles, and those are patients that are guarding, and it's different pathology from distension. Guarding is a way that our abdomen protects itself. Distension is when our abdomen starts to fill up with fluid or blood in the case of trauma or peritonitis, something like that. All right. Last thing is just going to be a review of the same cycle that I showed you guys in class in terms of our endocrine disorders. So over here we have our pancreas. Over here we have our liver. And then we have a cycle that occurs between these two things to keep enough sugar in our body. So our pancreas, let's say some sugar comes in from the outside. So glucose comes in, and our pancreas is going to release insulin. It's going to release insulin to make the sugar levels go down. Remember, insulin doesn't make sugar disappear. Insulin is the transporter that takes the sugar into the cells. When we have low sugar levels, so if we have low sugar, some of this sugar is going to go into the liver and it gets stored as glycogen. We sort of save that for later. It's like a little snack. When we have low sugar levels in the blood, the pancreas sends messages sends glucagon, which is another one of our pancreatic hormones, to the liver. Now the liver releases sugar. It goes through glycolysis. And we end up back here where now there's extra sugar in the blood, and the pancreas will reduce insulin to put that sugar into the cells, and on and on and on forever. So, broad scope, insulin, if I can spell, insulin makes sugar go down. Glucagon makes sugar go up. And then obviously taking in sugar, usually orally by eating and drinking, is also going to make our sugar go up. As I mentioned in class, the big indicators that test questions will usually use to tell you if it is a sugar too high problem or a sugar too low problem, if it doesn't just give you the sugar straight outright. The big indicators we use is that our hyperglycemic patients are going to have hot, dry skin and rapid, deep respirations. And our hypoglycemic patients are going to have cool, clammy skin and rapid and shallow, or late stage, slow and shallow respirations. They're not going to have those big, deep respirations that we see in our hyperglycemic patients because they're starting to develop acidity within the body. That's all I really have to say about the endocrine stuff. I'll remind you once again to review your toxidromes right out of the textbook. I think the book does a good job giving you the signs and symptoms associated with each toxidrome. So I encourage you to use that as a resource rather than do it here on the board. We're already just about 2 hours in. So I think we'll keep it to 2 hours for right now. If there are any further questions, I didn't get any in my email again this time, so if there are any further questions, you can email them to me and I'll reply to them directly, or you can comment them on this classroom post and I will reply right there in classroom, because if you're having the question, chances are one of your classmates might also be having that same question. Do you have a question before you go, Logan? I just saw your video pop back up. Nope? Okay. I will see you guys on Monday for your exam. Exam is first thing on Monday, right at 6. And after your exam, we will start into your trauma overview as well as doing your mid-class check-ins, either with myself and Majonica or with RJ and Majonica. Or if we can get someone to do what we're supposed to be doing in class, it might be with all three of us. But chances are it'll be with two of us while the other person is teaching. What else was I going to say about Monday? Oh, the chapter that is listed as due on Monday in your schedule, I have made due on Tuesday so that you can focus on your exam for Monday. It should be open in JBL already, but I did get a message from one of your classmates that they weren't able to see it, so I need to check in on that. If it's not open already, I will make sure that it's open tonight. I might have put the wrong date in for it to open. So I wish you all the best of luck studying for this exam. Please email or comment your questions, and I'll keep an eye on Classroom for anything that might come up. And I'll see you on Monday.